welcoming you all to this webinar labeled the Menopause Mission, and with a brief introduction initially to the European Health Futures Forum that is hosting this session. The European Health Futures Forum is, of course, a Irish-based but pan-European wide organization working across different disease areas, different futures areas, different areas of society and democracy in order to find a pathway for futures, for health, for well-being. With me today, of course, also, at least at this point, two other EHFF current members and possibly two other future EHFF members is, of course, Nina Sönderberg and Janet Michel, and also Aura Pykkonen and Laura Kelly. But first off, I am Lars Münter. But initially, let me introduce both Nina and also Janet Michel for a brief introduction first from Nina into the Women's Health Working Group and some of the elements that sort of describes why we are here in this digital room. So, Nina, please.
Thank you, Lars, and I hope you can hear me. Initially, Janet and I met in Copenhagen and talked about the lack of research especially in women's health and especially in menopause. And we looked each other in the eye and we said, we need to do something about this. So it all started with a passion and a mission. And from that on, it's been quite quickly, I would say, that Janet and I decided that we should have a working group within the EHFF forum to work with women's health, and starting with menopause as the main topic. And we might move on to other women's health issues, but right now it's menopause that is the topic that we're working with. And I was lucky to meet Janet, I think, because she already did some research and some data gathering in the Global South. And I wanted to do the same in the Global North. And since Janet is placed in in Switzerland, we could easily see that some of the guides that she already had used in the Global South and some of the framework that she'd been using could actually be applied in the Global North. So this was where this collaboration started, and a lot of other only female members until now has joined the working group, and more getting into it. So we're really happy that this is something that a lot of women from all sorts of professions are passionate about. We have researchers, we have psychologists, we have doctors, we have communication people, social scientists, a lot of different professions that are working within the working group right now. And also, of course, within the scope of the working group, time has also worked with us. So a lot of focus, especially in the Nordic countries, have happened while we had the working group. And then we met Laura, and then we met Aura. And then, I could keep on saying that this mission have just brought a lot of attention, but also a lot of really, really good people into this mission. So I'm so happy that this has started, and I'm really looking forward to see what the next year will bring, because I think that we move quite fast, but we also have a vision that's kind of that's very clear for all of us. So I'm really happy that all of you are present today, and I hope that we have a really good collaboration in the next years to come. So over to you, Janet.
Hi, everyone. So yes, my name is Janet Michel. I'm actually Zimbabwean, but currently working and living in Switzerland. And women's health, I always say, has become something very personal. So having grown up without access to menstrual products, so that I grew up knowing pure poverty firsthand, and then becoming an epidemiologist, trying to apply for funding to do women's health research and being denied, I realized the challenge of underfunding that is in women's health research. And then thirdly, as a woman who has crossed the 45-year threshold myself, I have come to realize that there's something called menopausal poverty. So when I met Nina, yes, we agreed this is something we should do something about. And now I'm based at the University of Bern. They've just created a women's health research hub, and the focus is on how this misdiagnosis in menopause is affecting the mental health of women. And I think that's something we should not, that's actually gets ignored. Thank you.
But please also maybe though, Janet, if we may, dive in a little bit into the types of data that you've gathered so far. What is the elements that, I mean, we've had medical science on this earth for quite a number of years, but somehow there is, of course, well, there's obviously quite a lot of stuff that we as human beings still don't know about our bodies. It seems that we've explored only a part of the ocean so far. But it seems it has also been so that we've forgotten that there's actually two different genders, and that the medical science has been mostly looking at, well, people like me, not people like you, white, well, Caucasians. And I think I fit the age too, something about 50 or so. But there are other people on this planet, and of course also others that should be sort of data gathered from, if you will. And that sounds a little bit wrong, but still, it meant well. So what is the kind of data that you're gathering in that menopause mission?
Yes. So thanks, Lars. Absolutely. So if you look at clinical research, the focus has really been on the male. So it's let's say white male in clinical research, and very few women have been involved in clinical research in the past few years. So what we are looking at is perspectives of menopause, and bearing in mind women's health research is neglected globally. So we have the Global North group, where led by Nina, and then there's the Global South, and there's another lady called Flutter who's coordinating the Global South. And we are saying, what are the perspectives of women going through menopause? What are their experiences? We are gathering real life experiences, and how are they coping? And we have realized that they are physical symptoms that they are going through, which make it very difficult sometimes to work. And then there are also social components. And in some of these contexts, we are talking about the Global South, where polygamy is accepted. So it seems a woman, it's like being a woman is like confined to being reproductive. So sexual reproductive age. As soon as you hit menopause, it seems you become totally ignored, and you are useless. And that kind of reduces a woman's role to procreation. But we are also seeing the women dropping out of their professions because they can't carry on working, the fogginess and the forgetfulness, and women think I'm getting an Alzheimer, but also this is compounded by the fact that the GPs and the gynecologists don't learn about menopause. So when they go there to seek help, they are being misdiagnosed, and some of them even end up on antidepressants and are ending up in the psychiatric unit, which is where we are saying the mental health of women is being affected by this neglect. And looking at how they are coping from the preliminary data from Zambia, women are just utilizing sometimes herbs that have not been tested, and this is leading to hepatotoxicity and nephrotoxicity and other side effects. So the women are suffering without any support, but also being, it's like the blind leading the blind, because the GPs and the gynecologists themselves don't know how to deal with menopause.
Well, I suppose then, in a way, it's good news because they also don't know in the global north. Yeah. So,
Fair,
um,
very true.
so that's for once there's some kind of equality or equity to it. But of course, with a very wry smile, saying that. Um, and in this webinar today, we'll be also able to hear some more also from not just, if you will, a sort of the view from Europe slash Africa, but also from Laura Kelly from a view from America too, where clearly they must be wiser than the two of us. And I can't see your camera right now, Laura, but I imagine that you're shaking your head a bit. But this will be very enlightening for all of us, and I look forward also to the fireside chat a little bit later. With us today, or perhaps kind of not with us today, is also Julia Persson, a Nordic entrepreneur that's been really from a background in working in financial technology, labeled fintech. Also, really been looking at how menopause affects their bodies. Could I possibly maybe mute? I can. I have that power. Rosemary, welcome. I just muted your microphone, but it's so good to see you here as well. I will just, Julia, she couldn't be here today. I think that she's actually in the US, and I hope, Laura, that you've figured out a way to meet. But Julia's been kind enough to send us a very short salute.
I learned about menopause twice. First, when it was too late, then when I became it. My mother was a Penn State scientist, stage 4 gastric cancer at 65, symptoms misdiagnosed for over a decade. I was 46 when I got my own cancer diagnosis, except it wasn't cancer, but surgical menopause at 46, and then left to figure out the cascade alone. What haunts me, both tragedies happened during the same window. Perimenopause to early menopause, the decade when chronic disease risk jumps 3 to 5 times, the decade healthcare ignores. Here is what nobody tells us. Perimenopause doesn't just affect our ovaries, it triggers cascade changes across 12 body systems simultaneously. We might see a cardiologist about palpitation, an endocrinologist about weight, a psychologist about mood, our GP for fatigue, 4 doctors, 4 specialties, 0 pattern recognition. Meanwhile, your body is screaming insulin resistance or thyroid dysfunction or atypical menopause, but fragmental care can't hear that. This isn't a women's issue. This is a system failure that cost Nordic women 20 to 28 years of healthy life. I'm closing this gap from both ends. Policy through Women's Health Vision 2040 and precision health management for each woman individually. I'm building Health Navigator, AI that does healthcare, that does what healthcare doesn't. Pattern recognition across all 12 systems, delivering through WhatsApp, the tool women already using. What if we could spot insulin resistance 18 months before weight gain? What if we could spot thyroid dysfunction before it becomes disease? The science exists. We are just making it personal. My hope that my daughter generation never hear these words, or you're too young to menopause, or maybe it's just stressed, or have you tried yoga? I want them to hear your body is changing on schedule. Here's exactly what to do about it, and let's keep you healthy for 50 more years. Prevention over diagnosis, intelligence over guesswork, health span over lifespan.
Let's move then to the US. And as I mentioned, Dr. Laura Kelly, clearly there's lessons from that wonderful country that's currently stuck in, I hesitate to say menopause, but clearly a midlife crisis or of sorts. There's lessons for us, or at least from you, on how we should maybe rethink or redo, research women's health and menopause. Laura, please.
Thank you, Lars. Well, I think there's going to have to be a separation between me and the system in which I really don't operate anymore. The system in which I operate does not do any of the things that we need the system to do. It seems that this sort of like the country should be something other than it is, and it's certainly in terms of healthcare, that's true. I'll tell you how I started this, and this will explain the situation. My mother, when I was in my last year of my seventh year of study of medicine, my mother came to me and said, I have really bad bone loss and I have to take these drugs, and then I'm going to have problems from the drugs, and I don't want to do it. So I did some research. I did a World Health Organization trawl and found a lot of information and gave her some things to do. She stopped her bone loss. Her doctor said this is a fluke. Anyway, it didn't matter. What happened is she reversed her bone loss after 17 years. So this was all natural, personal work, personalized work for her body. Um, I wrote some books from that. My practice became about women's health by default of writing books that became popular books. So women came to me and said, can you reverse the bone density? I don't want to take the drugs either. So I started working with women, personalized precision medicine, doing genetics, doing biomarkers for each woman. And the conversation then turned to hormones. And what I found in my practice was one of two things. Either women were not given any hormone conversation because the doctor or the provider thought that they would have a stroke if they took hormones. The second response was, here are the hormones, good luck. So there was no conversation, there was no medical investigation whether this person had carried any genetic predispositions towards reproductive cancers. There was no looking at who this woman was. So that happened, and I thought this was really bad. At the same time, I met Dr. Maria Yoloko, who was a sexual medicine urologist, who was going into residency programs in the US for free to train residents on what the vulva is and all of the problems that can occur with the female vulva because it is not taught in medical school. So she was aligned with an organization in the US, which was started by a 25-year-old girl who had had vulvar pain when she was 20 and gone to the doctor. And the doctor was like, I don't have any idea what to tell you to do about this. She went to 10 doctors in the US, well-educated, well-meaning physicians who had no idea what to do with this woman's vulvar pain. So she started this organization and started looking around and finding out, oh, women on average in reproductive years see 10 to 15 physicians in the US before they find someone who can help them with their vulva. So that's the reproductive area. And then we move into the menopause area, and it may even be worse. There's a 2% of physicians in the US who are comfortable talking to their patients about menopause and who seem to know anything or have any solutions at all. So this is a spread problem across all of the female life cycle in the US and seems to be also the case in the rest of the world. So unfortunately, the system here has nothing to teach you. But I certainly do. So I'm very glad to be involved here with you guys. So I've been working in, again, precision. Really, precision medicine is the way to go. Nobody is a statistic, and no medical recommendation is right for everyone. So from that position, we need to understand who this person is individually and treat them as an individual. So.
Oh, wonderful. So obviously wonderful that you, as a dedicated individual, Laura, that you've tried to make a difference in that. But the system wasn't really able to provide much knowledge for us all. So if we may, Aura, move then to, well, Finland, or at least that's where I think you are in Finland right now.
Yeah, I am. Yep.
Assuming. Is there then for us all from the Finnish system something to learn, or something that you learned back then, or more an enlightened system, or have you also been on a personal mission?
Thank you so much. Lovely to meet you all. Wonderful intros already. Very intrigued by everything. So I'm Aura. I'm an obstetrician gynecologist. I've been trained here in Finland and I lived a little bit in Copenhagen, so I have a lot of sympathy towards the Danes. I love Copenhagen, and I worked in Sweden. I did my PhD on the obstetric side of things and on the beautiful Nordic medical birth registry data. We have fantastic registries, and they are filled with fantastic data um, on certain things. A lot on births, not that much on menopause, which probably is not surprising to anybody, but there would be a lot we could still withdraw from them if we bother to do that. But that was kind of like a side note to that. But it kind of I'm a big believer in the sort of in the big data. The big data would give us some clues on how to then deep dive into the what Laura just talked about, the personalized medicine. So I think we need the big data first, and then we can actually access the real personalized thing. But so my I after working in the biggest birth unit in Finland for a few years, I was on my way to become a perinatologist. Sorry. Well, anyway, an obstetrician, and I just I think the word is I burned out. I had a sort of a moral dilemma towards how my values were not really in alignment with how the care was delivered, and we're not even that far off here in Finland. I think we're much better off than in many other places, but it still was very much of a factory-like thing. And especially the thing that caught my attention the most was the miscarriages. And how whenever a woman went through a miscarriage, the treatment was to tell her how normal it is. So you shouldn't be worried, you shouldn't be too sad, just carry on. And then we have this whole system around trying to stop these women coming to the emergency room or coming to the clinic at all because it's so normal. And if you're not bleeding, enormously, just stay home. And it felt so wrong, especially when we're having that conversation around the decreasing fertility rates and how nobody's having kids. And I knew that these 35 plus women, I lived in the capital city, and women, they are getting older everywhere when they're starting to think about having a child. These 35-year-olds were having their miscarriages and then told that, take care of it, you'll be pregnant again in no time. And then we wonder why nobody's having kids here. So it's really, we have this conversation and then we really don't do anything about it. So that kind of pushed me out of the hospital world. And I put up my own telehealth clinic for women. And I thought that that's something that is disruptive because at least I wouldn't be able to look at because don't get me wrong, Laura, I do think that doctors should look at the vulva, but it's just that somehow the gynecologists, they are reduced into physicians just look at the vulva and they don't really talk to the patient. And I just wanted to change that a little bit so that there would be this more holistic, more compassionate, more sort of empathetic way of treating the women and actually learning to know what's their, root problem and what they and educate also sort of like in an individual level. And then through that clinic, I quite quickly learned that the biggest need was not in the miscarriages. The biggest need was in perimenopause and obviously also the different mood disorders around the menstruation as well. So PMAD or PMS symptoms and the overlapping of PMS and perimenopause around late 30s, early 40s. And I got really intrigued. And what struck me the most was that I realized that I had no education about this. And I am the physician that the GP should refer these patients to. And still, like, my knowledge is very limited and it's very narrow. And it's, as Laura was very much to the point, they're saying that, they're throwing the hormones are thrown to the woman and not really explained what to expect, how to use them, what should be monitored or how to monitor, and then quite quickly the understanding that the answer around why we don't measure your hormone levels is because it's so darn difficult that we don't know how to do it. And it's such a lazy argument, and but it is what the medicine today has to offer. And then kind of these type of dilemmas pushed me even more towards the startup side of things, where there's a lot of innovation going on. There's a lot of highly motivated, very visionary people out there building solutions that are sort of fast forwarding medical research. Sort of they're pulling together what already exists, because there is quite a lot of research also in menopause, but it's just not really used, and it's not really taught, and it's somehow dropped, and everybody picks up their new research without really, because it's so, I think it's also has to do with the root cause of having this gender medicine issue here, that it's somehow it's forgotten and then it's dug up again after 20 years or something like that. Anyway, we underuse the existing data. And now these startups are very smartly pulling together the existing bits and doing their own part of it. And we do have, what I'm most excited at the moment is around the solutions for continuous hormone measurement. I think those are one way forward around personalized medicine and around finding the right hormone replacement therapy, for example, for women to use. Because now it's just basically one size fits all. And obviously, one size does not fit all. And also the indications that what do we use it for and what do we want to gain and what are the odds that we would gain any of those benefits. And I'm very, very early on my journey to become a holistic doctor, in the sense that I believe you, Lara, are, in the way that I could implement a sort of personalized medicine in the deep sense of it. Now it's more like I just try to get to know the person and the medical history, but since there is so much that the medical history doesn't cover at the moment, I think we need more tools. And then just one final thing around that personalized versus very general medicine, that I guess all of us from the Nordic countries, we represent at least I think from a US angle, you could say socialistic medical system, but a general public healthcare system where it's technically for free, practically not, at least in Finland. People pay quite a substantial amount of money out of pocket. But anyway, the services that are offered are very general. They cover, there's the same for everybody, except for gynecology. For that, women have to seek their own care somewhere outside the system. And for this very, very general system, and we still lack a lot on the prioritization conversation. We need to do more of that, because medicine is going fast forward and the system is not, and we don't have money to do everything. And so basically we don't really know what to do today in the system. But this system is so far from being personalized medicine or representing anything around personalized medicine. And I just think that this is part of the problems and part of the crisis that we're facing with our healthcare system in the Nordics. But yeah, a lot of thoughts there. Lovely to meet you all. Very excited to hear more about you and your work. And yeah, thank you.
To some extent, though, Aura, being in a crisis sort of implies that there's something different than what normally would occur. But in a way, I suppose what you also, all of you, describe is a status quo that has never really worked. So more than saying maybe that this is a crisis, this is also an awakening.
Possibility, yeah.
Awakening of a non-willingness to accept that status quo, both for you individually, but also for you collectively, which is, well, to me personally anyway, but also to the women and men of the world, wonderful that indeed someone is actually willing to say no more. and to make a difference. Um,
Can I just respond
yes,
to
of
that more a
course.
little bit? I don't know if that's the format here, but
Well,
I think that
so,
there's another thing. It's sort of that the system itself is sort of cranky and old and not really addressing the issues based on the science and the knowledge that's come before. But it's also not looking necessarily at all of the right data anyway. So even if the system was sort of properly functioning, what I don't see and what I have built, or and this we can talk about this, is a look at this woman's risks and this woman's situation in terms of what a hormone means in this body. Because you can have great genetics for estrogen metabolism, but if your detox functions are not working properly, you will create a damaging metabolite that will damage your DNA and you will get breast cancer anyway. So the system is entirely missing the aspect of actual mechanical function of your estrogen detox system, which is the place where your body decides whether you're going to damage your DNA or not. So this aspect of medicine doesn't even exist. So, I mean, I look at this, I built a system to be able to look at this in individual women because I can't make a recommendation for that woman unless I know how her system is managing what I'm maybe giving her. So, this is missing from the system. And I think that that's the other part of it is actually from a mechanistic standpoint as female bodies, what are the mechanisms at play and how do we make sure we understand them so that that individual is healthy?
which is a good point in many ways, but also begs the question. Even though I said before that the medical system was looking at men like me, I question whether it looks actually at anyone, because it's not really a personalized approach. It's
No.
the imagination of a human being rather than actual listening to any human beings, and certainly not women for sure. Um, what would it though take though? Um, Better listening skills for sure, um, but also better data, better training. So where to begin? What is the one of the things you would either you, Laura, or you, Aura, really recommend that in that global survey that Janet and Nina is taking on with the rest of the women's health group that they should remember to ask whether they listen at all, whether they care at all? No, well, whether they care, they possibly not, but whether
Well, I
they,
think they care. I think they care. I just think that the training isn't, there are too many things wrong with the training.
so that's actually one maybe to add, if possible at all, beyond the scope of the menopause that the women individually experience, to have some data about the level of training. I think you mentioned that only 2% of doctors in the US were willing to talk about the vulva, um, and even less so have had any training at all. Is that also true? I mean, I'm judging, I mean, I should be take care here, but I think, Aura, that you went into training slightly later than Laura. So has that changed potentially, or is it that different in Finland?
I it certainly hadn't changed when I went to med school in terms of it. I think it has changed over the past 5 to 10 years that we are a bit more aware of gender, and I most of my work today is advocacy around gender medicine and just trying to tell doctors that there are two sexes, and it's it's insane how unrecognized fact that is. It's laughable, but it's then again it's not. Um, so it has changed in education, but way after I went to med school. I went to med school early 2000, and it was, I guess it was reflecting of the cultural, social environment in Finland at that point, which was, I guess, progressive compared to many other places, but not then again, not very much. It was way before Me Too. I think Me Too did a lot of change into so many different fields we couldn't anticipate it would change. And actually, when talking to my US colleagues, I hear that it's not completely and only positive in terms of medicine, because I'm not sure where that 2% you mentioned, Laura, comes from, but at least when these medical founders, when sort of doctors that had founded a company or were thinking about founding a company around some health solution, they said that it's really difficult to talk to investors around, for example, the one had a solution for vulvodynia, the vulvar pain Laura mentioned there, because it was so hard for the men to say the word vulva in a meeting room, and they just wanted to avoid getting into the situation where they'd have to mention that in order to avoid of being accused of being not sensitive enough or offensive in one way or another. So I think that's also a two-sided coin, and I think there's also that kind of like this awareness brings also this side effect thing that it kind of like gets to be an overkill, and people just get too worried that they might do something wrong when they touch the topic, and then they don't touch the topic at all, which is terrible. But I do think that things have changed towards better here in the Nordics in terms of medical education, and in terms of, I think it's not, we don't talk about atypical symptoms in women anymore, for example, for cardiac arrest, because it's just the typical symptom on the 51% of the population. It's just not the typical symptom in men. But I was taught that women have atypical symptoms when they have a cardiac arrest. And how do you say that it's not typical when it's for 51% of the population? So that's, I think, the biggest, it's the biggest killer in women, obviously for men as well, but something that most people, at least in Finland, don't know, that 60% of people going through a cardiac arrest today in Finland are women. So it's a women's disease nowadays, and we've been able to lower the incidence among men steadily since the 90s, but women, flat curve, or not curve at all, flat line, because or even a slight increase actually in the early 2000s, because we just don't try. We don't even, even though we know that, for example, preeclampsia or gestational diabetes would put these women in, or endometriosis would put these women in a higher risk, and still we don't treat these women any differently. We don't use any primary preventative tools on them. Again, going to the precision medicine, that we should be able to pick these women from the population and see their personal risk.
So time for men to have atypical symptoms. But also, though, I heard, and I think maybe also that could be from the Victorian age, that euphemisms kill people when we're not able to really talk about real issues, but I sort of think that it's not really nice to talk about things that are in our reality because of, well, politeness or other issues. I think we have a question, though, or a comment, Nina. Is that a nice comment or sorry, but certainly something to add to the language that we have.
Yeah, I don't know if it's a nice comment, but I would have liked to have a Finnish doctor I could hear from what you just said, Aura, because I am also a heart patient, which I have very abnormal symptoms, and it's really difficult to figure out what to do. So I had to take a decision myself about what to do with my heart condition. But that's just a side note to what I was just talking about, what I was just thinking about. So I work a lot with mental health issues and a lot with especially women suffering from mental abuse, domestic violence, but also sexual abuse. And once I've worked with the women, I also through therapy and when they have an understanding of their own story and have a language for what have actually occurred to them, one thing that's still sort of lacking is their sexual activity or their sexual their to feel safe in a sexual relationship with a safe partner. And of course I could work with that, but I can't really work with the sort of the body sensations that they might need a specialist to figure out there is nothing wrong with your vulva, there's nothing wrong with this and this and this. We did all the tests. Now that that you feel better, this might be a way of dipping the toe in trying to engage in a sexual activity again with a safe partner. But I don't have any specialist to recommend when I sit with my clients and they say, okay, I start dating again, but I can't really see myself in having sex with somebody again because I don't feel safe. I have pain. I'm not really sure about how to feel about my own sexuality anymore. So all this education, psychoeducation, literacy in sexual literacy, maybe sexual health literacy, is something that could be really cool to talk about. How can we frame that in better ways? Even though us sitting here, we know that this is really important, right? And also because sex and having a good sex life is actually a key element in having a high life quality. But if we don't dare to talk about it, it's kind of in the shadows, right? So how do we engage with more conversations about this, also with men or other genders in general? What are your opinions on that or comments to that?
Clearly an area that have been historically difficult for human beings to talk about, even though it's one of the bases for us human beings to still be here. An opinion maybe on that, either or Laura or Janet,
I would love to hear from Janet as well, like from a very different Global South perspective and also very different perspective on
Yes, I think that's one of the topics women in menopause raise, that as soon as they get into menopause, first of all, there are certain things physically that they experience, like the vaginal dryness, which makes it difficult for them to engage in sex. And that's something where they are trying to come up with herbal concoctions to help themselves. But secondly, there's that element where the language itself in sexual reproductive health, it's called sexual reproductive health. It's not called sexual reproductive and menopausal health. So that kind of reduces the sexual activity until menopause. After that, you are not expected, or nobody thinks you should be having a sexual life. So that's this also cultural component, but also where it's like people think if you're in menopause, you don't engage in sex anymore. But the other thing is also that the men tend to lose interest in women who are in menopause, which is really also affecting the women mentally.
But is there then, I mean, aside from a stern talking and maybe some good books to be inspired by, what are the kinds of solutions that you can also maybe find out there? I seem to have heard at one point, Laura, that you at least have explored options that would sort of cover some of that gap, in addition to, of course, having better information at hand.
Yes, I mean, one of the things that I'm doing is I created out of the conversations with women around bone health, it became a conversation about hormones, which is why I developed this look at at women's individual bodies based on their, detox capabilities and their genetics for reproductive cancers. What came out of that was the discussion, the secret discussions, right? The discussions that they didn't have with anybody and they didn't even want to have with themselves, which is I have pain, I don't have intercourse anymore, my relationship is falling apart, I pee all the time when I laugh, or sometimes it just leaks and I don't know what to do, and there's nobody that, and they go to their doctor and the doctor says, oh, it's just getting old, you just need to deal with it, right? Or here's some SSRIs, here's some brain medication because it's, here you have problems in your brain, right? So I looked at this and I was, younger, 10, 7 years ago before I went, approached menopause. And I was like, God, I don't want this to happen to me. This is really bad. This is a terrible situation. So I looked at creating a solution, a topical vulvar solution that was going to help manage some of these problems and developed that. And so now my little company is launching with that solution. And but what I am encountering as I'm starting to bring this, to birth, is that even women do not want to talk about this. They may talk about it in their physician office if they're an open-minded physician who seems to know something about it. But going out into the public, which I just did 2 days ago, women were standing in the back telling each other about their dryness problems and how their relationships were suffering, and they would not come and talk to me. And so not only the men, not only the system, but the women themselves with the problems. And I am literally today sitting around thinking, how am I going to address this? Because without them coming and engaging, they're not going to have the solution. I can make solutions all day long. But unless there is some way to bridge that gap of fear or taboo or whatever that is, then the solution and the person don't come together. So I think a great exploration for me, and I think for all women, is to sit down and figure out how do we start bridging that gap? How do we start bridging that health literacy and make it okay for this conversation? It's part of your body. We have to make it okay to talk.
Aura, yeah,
Yeah,
please.
I think I commented something on the text, but I think that is a huge and highly important topic, but that's a huge one that goes, through the whole culture towards to the children and how we talk about our private parts when they're kids. And it's just an anecdote. I have 3 kids, one daughter, 2 sons, and our youngest boy is 7-year-old now, and he sometimes wake up super happy in the morning, and he's having I'm missing the words. I'm not a urologist. And it's a boner, basically. He's having a hard on, like that tiny little, and he's just so proud and happy about it. And he goes and shouting like, my little guy has waken up. It's morning, and it's like this proud moment and fun, and it's, nobody's shaming him. Nobody's, telling him to, go to the bathroom. It's a private thing. And everybody, it's kind of like a fun thing. Whereas we don't really, my daughter is probably soon going to menstruate, and it's still something that we it's an odd conversation. I'm a gynecologist. It's still sort of like an odd conversation, and her private parts are not shown anywhere. She doesn't walk around. I mean, these are just individual things, but it's just that I've been thinking about it quite a bit, that how do we even talk to the kids when they're young, super young? And I mean, I live in a relatively liberal culture, so we're naked all the time everywhere, but it's still it's still different. The nakedness is still different in Finland for women than it is for men. It's different for boys and it's different for girls. And I think it kind of like answer to what Laura brought up there is around like how do we talk about our private parts from the day one, and how do we teach our kids to talk about their private parts, and something. But I think I see a tiny change. I think, and when some people are vocal about it, they eventually it will change. I hope. I'm hopeful, but it's for sure it is that way, and especially when nobody brings it up, it's even harder for the women to do that.
One thing that I've noted that also I think is part of the Women's Charter 2040 is the normalization of the conversation. But of course, in this context, not just the ability to have the conversation with children, but also have the conversation across generations. I mean, to some extent, part of this conversation is one whether it would be really good if more women in menopause or having experienced menopause would have more conversation with, I don't know, teenagers or women in their 20s, way before they actually, if you will, need to know. Well, they all need to know, hopefully, at one point, if they grow old enough. But have that conversation across generations. I mean, and of course, it's difficult, as Laura describes, when you can't even have a conversation within your generation. But is that maybe part of the solution also to be able to at least have that? I mean, I know that with a smile, teenagers are really difficult to have a conversation about anything. That's sometimes, but they do care about stuff. We clearly see with climate change, they're very passionate about some things, and they might also be really passionate about women's health too. Is that part of is that possible? Is that to evolve the advocacy? Yeah, evolve the advocacy for sure, as well. Is that part? Yes, please, Janet.
Yes, so when we had the launch of the Women's Health Research Hub at the University of Bern, and we had young females who were there pre-menopause, and we had others who were like, the perimenopause and the menopausal women. And the discussion there, it was really interesting. The young women were very happy. They say they want to be part of this discussion because their parents don't talk about menopause. They just see their mothers maybe having hot flashes, but they don't talk about it. And they would like to learn and hear more, and also really know about what to expect in menopause or in perimenopause. And the same was applies to the men, the allies who were there. They say they see their mothers or partners having hot flashes, but they don't talk about it. It's a taboo topic, but they would like to know more and be of support. So it seems there is that desire to have this intergenerational, but also gender or different sexes. The men are really willing to also learn more and be of support.
I don't know, obviously, Aura, whether yet that was when you said you see things changing, whether you were talking about an intergenerational change. But is that possible, perhaps? Oh, Laura, I was going to ask Laura, but Nina, you have a comment, so let's go for that one. More about vulva advocacy?
Yeah, I'm just thinking about to be able to have the conversation is also starting to have the conversation. So who's going to start it? Who's going to initiate it? And we're starting here with a webinar, of course, but how do we start this conversation that Janet was just talking about? I think that one thing that I noticed, I'm 48, and a lot of my female friends are the same age. We all think that it's really, really important to have work places that consider menopausal symptoms, that are friendly towards women that experience menopausal symptoms, etc., etc. But no one wants to admit that they are in the midst of having menopause. Why is that? This is this is not. It doesn't make sense to me. It's well-educated women in the end of the 40s, maybe start 50s.
Sexy. It's not sexy.
It's not sexy.
Yeah. We lose.
Apparently, we lose something in our own perception, and that's why the vulva advocacy could be a way of trying to, I don't know. Everything shouldn't be around being sexy, but how can we make the conversation matter to people? And just say, okay, I experienced these symptoms, but it's not something that I just want to laugh off. And now I'm having a hot flash. That's really funny. No, it's a natural thing. It's something that happens. Like your son, Aura, that says, "Oh, this is funny. I'm waking up like this," and the little guy is also getting up in the morning, right? So it's just sort of how do we normalize this even more and get people to talk about it? I think we need advocacies even more. Yeah.
Whether the yes, sorry, Laura. Yes, you go.
May I? Well, I mean, I think there's two things that occur to me, and one of them is that it's not normalized because the system doesn't have solutions, right? It's like, okay, if you have high cholesterol, like let's leave out that discussion, but if you have a problem like that, there's a statin, okay, and then you move on. And it's not like, oh my God, I have this thing, what am I going to do? And it's terrible. You have a solution, and then you're like, okay, so it's fine. And people talk about it, and it's fine, and they move on, right? And I feel like because there's this no solution system, then it's like, oh, there's no solution. What am I going to do? I got to hide it. I got to write. So it's like there's a system normalization too that comes with the system recognizing the problem, not just the women recognizing the problem. And I think that so there's that aspect of it. I don't know if that helps anything, but I think it's an issue. Um, I think also there's another way, which is the discussion on women's health. And it's not just about your vulva. It's about your bones, right? Because when you're talking about, and this isn't kind of like a place to enter in the discussion with younger women, your bone density peak is around age 30, 34 maybe. If you do not build that by then, you end up with problems later. So that's a conversation you want to be doing that in your 20s. So you want to understand that genetic predisposition. You want to understand that situation. If your parents or your mother or grandmother had a problem, you want to be knowing that and you want to be working on your bones when you're 20, 25, 30. So that's an entry point for discussion on women's health. And so you get in, you talk about your bones. The bones are related to hormones. The hormones are related to vulvar and vaginal health and brain health and cardiovascular health, right? So I think that there are potentially places that you can enter the women's health discussion that isn't like, let's talk about your vulva, right? Which is not bad. I think we should be talking about our vulva, but we have to meet people where they are. So there may be other entrance points on a women's health discussion.
Well, yeah, sorry, Janet.
Yes, so just to add, right, this lack of knowledge, it's not only so the women themselves very often don't even understand what they're going through, right? I think that's the one thing. And I still have my mom, and she still asks me, I have this and I have that, and I'm thinking that's menopause, okay? But she still doesn't know. She's scared. She thinks there's she's got something very a debilitating illness. So then there's also the healthcare providers who don't understand what the woman is going through, who the woman goes to for advice and for support. And then you have the society that also doesn't understand what the woman is going through. So when we look at this education, so what we term comprehensive menopausal education, we want that everyone, the woman gets knowledge so that they understand what they're going through. We want that the healthcare providers also get knowledge so that they know how to support the woman. We also want the employers to get this knowledge so that they know how to support the women at the workplace. But we also want the men and other generations to understand what menopause is about so that they also can provide support to the woman. So I think if so women themselves, healthcare providers, men, everyone, the whole society understands what menopause is, that's maybe one way where we can really have women feel supported and understood.
Absolutely. Aura?
Yeah, I would like to follow up both on the vulva advocacy point and what Laura brought up there as well. I had a little bit of a same comment around it, but I think going back to my telehealth clinic is that it's also important that we highlight the bits around women outside of their vulva or their uterus, or even around even outside of their ovaries, so that it's kind of like it's part of them, but it's not the whole. It's a tiny bit of the picture, because it's so much more. The immunology is completely different, and that is probably the most accountable factor for the chronic disease burden that women carry in comparison to men. And then obviously the cardiovascular health that we've now mentioned many times, and the neurology, migraines to name the biggest burden around the working age women, and then dementia when they're older. And these are all kind of going through the menopause as well. And then adding to I fully second the comment around that healthcare professionals want to avoid the topics that they don't have a solution to. They kind of like, hush these people away. I think also one completely neglected area, that this is a tiny issue now. We're talking about 2% of women going through pregnancy, is the excessive nausea and vomiting of pregnancy, hyperemesis. So that's something that we don't have a proper solution for. So we just neglect these women. We tell them that be happy that you're pregnant, and you're obviously strongly pregnant because you're vomiting so strongly. When it comes to menopause, I do think that there is, at least now it's a fantastic thing. We have a guideline in Finland how to treat women going through menopause, which is fantastic, because it's 50% of the population, and according at least to the estimates that we have here in Finland, about half of the women have severe symptoms, and at least 1 out of 4 would need some sort of a medical, probably hormonal replacement therapy. So that's basically 1 out of 8 in the whole population, and it's not something that some subspecialty can treat. There needs to be a general awareness around it, and it needs to be something that GPs can also attend to, and then refer some of these women that are more complicated cases. So my point was that we do have now a guideline for this, how do I say, general population, but this guideline completely neglects the women that are still having their menstruation going on, because still the sort of the general medical view seems to be that as long as you're still menstruating, you have enough of everything in your body, and you shouldn't be experiencing any symptoms that your hormones are to, or your reproductive hormones are to blame for, and therefore we don't treat you. And when these women come, and they typically claim, at least from on my experience, they complain about cognitive dysfunction, about mood disorders, mental health issues. Their relationship is going bad. Their relationship with their kids is insane. Typically, their kids are teenagers or approaching teenage years, or even worse, I think, is that they're going through their perinatal period once they're also perimenopausal, having their kids in their early or late 40s. So it's a lot for many women, and for those women there is really nobody. And going to your comment earlier around who to refer these women around sexual health, we do have a clinical subspecialty, at least here in Finland. They're called sexologists. They are typically physicians. They can be midwives or psychologists or psychiatrists, but typically physicians from there. And I think it's a 2 or 3 year training even. And what I do with these patients, I have like a handpicked name list. I know who to refer these people to, who are the good ones, but it's not really on a system level thing that these could be found. But this is definitely also a thing that would be needed, that it shouldn't be reliant on one person knowing another person that they can refer their patients to. Sorry, that was a lengthy one. There was so many things that I wanted to touch upon that you mentioned.
Well, being inspired by the conversation is kind of the purpose of the conversation as well. But maybe, and pardon if I'm detouring, and otherwise you'll just detour back, so that wouldn't be a problem, I suppose. But when we're talking about puberty for all of us, we tend to not really think of it as a huge problem, because there's something good waiting at the other end of it. I mean, I know that you have problems now, and I know that you have brain fog, and I know blah, 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 but just wait. Soon you'll be adult. You'll have so many good experiences from that. I recently came across this wonderful element, thinking of especially the different life stages of women, where in principle menopause was, of course, also the gateway to, well, wisdom as well. That wonderful age where finally you would achieve that also the stage of life where you just wouldn't give about a lot of different things that you used to care a lot about, but and you had carried for a long time as well. So, is there an element as well here that we could be better at talking about the wonderful thing that actually awaits women at the end of menopause, where you do not think of the problems per se, even though you should, of course, do something about the severe of them, but the fact, though, is that there's nothing wrong with you per se. You're just on the verge of wisdom. Is that also part of the sort of a part of a solution where we can also maybe, like you've mentioned before, Laura, have a more positive conversation about that phase because it's one that's just on the stage of something wonderful.
Yeah. I mean, I'll go quickly. Um, the Chinese medical philosophy is that it's the second spring. And that is it's a wonderful concept because it can be. If you're not buying into what you're told, which is that, okay, well, you're now everything's going to hurt and your joints are going to hurt and you're not going to be able to do what you used to do and you can't go skiing anymore and your sex life is over and nobody's going to find you attractive and all of these things. And your brain won't work anymore and your vagina won't work anymore and everything, right? If you don't buy that, then it literally is the best part of your life. Because you have all of this incredible wisdom and all of this knowledge and all of this connection to yourself that I'll speak personally, even though I don't usually do this, that I didn't have when I was younger because wasn't sure of myself and I wasn't, I didn't know what to do and was I right? And now none of that's all gone. I am 100% confident in what I do, what I love, who I am, all of that stuff. And all of those symptoms from the real physical problems that come with hormone loss are manageable. And once you do that, manage all of the symptoms, manage vulvar and vaginal health and care, you have a vibrant and incredible sex life because now you're completely confident in yourself where you weren't when you were 20. You have this incredible mind that can now function at much higher levels than it did when I was 20. And all of that is 1,000 times up leveled. So that is an entirely possible situation for every single woman I have met and treated in my practice. But that knowledge is not in the common discussion and it's not in medical science. I mean, it is in medical science. It just isn't put together and applied. So I don't know, I don't know how we find a solution to that, but it is entirely possible that this is the best part of a woman's life, without question.
Well, kind of, yeah. Thank you, Aura. And Nina, well, I think you were second before Aura, before Nina. So let's go to you, Aura, first.
Thank you. Thank you, Laura. I think that's very, very powerful. And I think this is again repeating what we've already discussed about that we just need voices. We need to change that the talk around the topic can be changed slowly but steadily. It can be done. And it's very powerful when we hear these also personal stories. But I think one scientist that is doing also, I think, good on this and is very visible today is Lisa Mosconi doing the dementia research or dementia risk on women and hormone replacement therapy also there in play because she has very much her theory revolves around and her books revolve around the upgrade in brain, like you have a sort of your system is booted for a better version of it. And I think that's just resonates and kind of like reflects what you just said there. And I think we need different sources that change this talk around it. And but obviously our work life and everything has been so quick, efficient, and it's not really around the common Western ideology to sort of have that conversation. But I also think that that's, on a verge of a little bit of a change. So I'm hopeful that we might. But thank you so much for sharing. I think that's super powerful.
Absolutely. More voices like that one, and soon you'll have women lining up to get menopause soon. But Nina, please.
Yeah, I totally agree with both of you. And I think that the storytelling part of it is really, really important, to have all the narrative, personal stories, because that's usually what we see can actually drive a change. And one thing that I was thinking about while you were talking, both with Laura and Laura, is that, the happiness reports or surveys that we see in where Finland is always topping Denmark, no competition here, Laura, is all is also one thing that stood out for me. The first time I read some of these reports were actually that the most happy decade of people's life are the 70s. The 70s. Wow. So Laura, what you're talking about, it's just let's open this treasure box of opportunities and happiness that we can actually gain if we're open towards not being afraid of getting older, because it's getting wiser and more happy, right?
Yeah. But the other component of it, and this is why it's so important to do the medicine side of it, is that it's chemical. Like a lot, what's going on in our brains, what's going on in our bodies and our vulvas is chemistry, right? It's physics and chemistry. So that is just real. It's not just a psychological issue, right? So there is a co-effort of the mental space around this and the discussion around this, but also the right chemistry and the right medicine to manage that. And when those things are in concert, the sky's the limit, right? But you have to have both of them.
Yes, please, Janet.
I think just to add, in the African culture, we see our grandmothers as people who have wisdom, right? And I think that's what we should really, they carry this intergenerational wisdom that is needed in the family, as we know, grandmothers and the roles they play, but also the intergenerational wisdom that is needed at the workplace. And I think that's where we are really, the employers are missing on this, because when women resign, they are losing talent and that intergenerational wisdom that is needed for productivity, but also innovation and stability at the workplace. So I see menopausal women as community connectors and also cultural, repositories of knowledge and wisdom.
Is that then maybe as a question the element of wise older women sort of exist, of course, in a European or American culture, in sort of maybe more in if you will, in fairy tales more than in real life. But is it something that is possible to really draw upon as a strength? I mean, and maybe as a wrong analogy, but back in the days before the Cold War ended, you had grandmothers of the Soviet Union that were really a fighting force for change. But is it possible maybe to better activate those grandmothers again across globally to really fight for menopausal health or women's health, so that they are really that voice of wisdom that we can draw upon for everyone to benefit from? But that was an open question. I wasn't hoping for silence. So
There would be go, Janet.
Yes, so I was just in Ireland for this Ireland Global Health Network meeting, and one of the resolutions was women as peace building communities, and that we should be seeing more women really involved in this and advocating for peace in the world. And I think women have done that, as you have said before last. But we're also looking at, for example, during when there's a crisis like the HIV epidemic in the southern Africa and in the region, it was the grandmothers who actually got up and they raised these orphans, right? So I think the women have in menopause have been a force to reckon with for many generations, but we kind of forgetting or we don't want to acknowledge that.
But well, yes,
Laura, Laura, go first.
Well, we also don't, I mean, I can speak for Americans. We do not have a culture like China, for example, where you have ancestral worship. We don't have that. It's not built into the way we think. It's not built into the way we're taught. So that's a huge problem. And for a culture like mine, I wish we did, right? That would change that response. So that's one big issue for us.
Laura, you also had a comment?
Up on that is the individualized culture, and I think very sort of individualistic thinking that has it is the problem. The same problems arise in perinatal period and around pregnancy. We don't have the village anymore around us, and we're very much alone. The families are alone. But going back to whether the grandmas could change this, I think that would require kind of like a two-way cultural change, at least here in the Western countries, because we'd need to, get out of this individualistic bullshit, to be fair and honest, and be more, apprehensive towards our family and family history. But also I think it's very difficult for, I think the younger generations are the ones that change the culture in a way, and the older ones preserve it in a way, if to put it in a very, I'm a physician, not an anthropologist, but just a thought that arose that at least when I would talk to my mother around her menopause, she's just like, we don't talk about it. Yeah, you don't ask, like you just go through it. And it's I think it's my generations and youngest ones' responsibility to change the conversation around it so that it's normalized, that these also women going, the older generations will be more comfortable talking about it and sharing their experiences once we have the respect, obviously, also for them.
Yeah, to be fair, I've also never asked my mother about her menopause. So, but kudos, of course, for trying, Aura. But maybe I got it wrong. I mean, maybe it's not really the grandmothers that should be more open in talking about it. Maybe also younger women should have the courage to ask their mothers about that and to gain from that wisdom. I know that there's a movement among men that they should be better at asking their fathers about their story to get them to actually, well, talk about their story before it's too late. And Laura went off camera, but I did have a question. If you're still sort of with us, Laura, or will be with us in a second, I'm hoping to maybe, without talking too much about orange policies, it's clear that there's a sort of a movement, you might say, in the US currently that has a significant impact on women's health. Is that then also maybe though one where you also see a kind of I used the word awakening earlier, an awakening among American women that there's actually something that they need to work for a different trajectory entirely. And maybe kind of the same awakening that you also describe as a challenge, Aura, that we need to go away from that individual mindset into one that's well, quite a lot more collectivistic.
Definitely. The orange policies, I don't know if everybody knows, probably do. But one of the first things that the administration did was put out a list of words that you could not have in your grant proposals. And if one of the words was women. So that's a pretty powerful indication of what's happening in the US. Before that, the movement had already started. There was already discussion. There were already, celebrities had become of the age where they wanted to not feel the way they did, and so they would start talking. celebrity is very important in the US, and this drives a lot of that, and there's nothing wrong with that. It's very positive. And then when this happened with these policies, obviously that went into overdrive. And so this particular universe works, right? If there's pressure in one direction, there's an effect, right? And this is the response, part of the response is that this discussion is now all over the place. And in terms of femtech and development for startups, and the market, there's a huge amount of money going into this. And so it's an actually wonderful time to be part of this discussion in the US. And again, the consumer-driven market is always or almost always ahead of medicine anyway, right? So people are able to then make choices and have products that are going to assist them that they would not be getting from the medical system. So there's a whole bunch of positive things happening in the US, as you're saying, around this, which is, again, wonderful to be part of.
Possibly too strong to say that we should be thankful of Orange policies for setting this in motion, though. Aura.
That's too strong.
Yeah.
Just a quick comment on the economics, because obviously we're not big in business here in Finland. We're more on the common good. But anyway, it's Slush. It's the startup week. It's the biggest tech startup event in Europe, I think, that is starting tomorrow. And we do have this rising around also femtech, but interestingly, none of that is represented at Slush. It's very much represented at any event that I ever go to on the other side of the Atlantic. But I've noticed that whenever I start talking about the economics around women's health, about the productivity losses, about the productivity losses, namely. So that's when the doors open and people start to listen and men engage. And that's how I got to talk to the Minister of Health around it, because it's money, it's loss of money. And that's, I think it's also important for us physicians, especially in this country that is not very business oriented, and the physicians even less so, to understand how to talk about the money involved, because that's a huge driver also for the good, and how to just put our words around it, that we're aiming for good, but it's still that we need a lot of money to do that, and we need to make a lot of money to do that.
Well, one would, of course, wish that at one point loss of quality of life would have that same effect for certain ministers, but that's a...
Now it's only an intermediate.
Discussion.
We lose the quality of life and therefore we lose money. Yeah.
But we have slowly run, Janet, I'll go to a second, but we're slowly running out of time. So maybe also in your comment, Janet, we are on a menopause mission. So from when we end today, where is your first destination on that mission as well, Janet? And do also add your other comment as well.
So I just wanted to add to what Aura said. I think it makes really a lot of sense to look at the aging population in Europe, and also the aging human resources for health, right? So we have 70 to 80% of the human resources for health are women, and more than half are in menopause or past menopause. So I think if we want to make sure that we have carers, because we have a projected human resources for health in 2030, then we need to have menopausal friendly policies in place. Thank you very much for I think that's something that we need to talk about. Last, you said, where are we?
Where are you going on your menopause?
Where are we going? Yes, I really love the very, very fact that we are forging partnerships. We have more people coming on board. So, and allies, Lars is one of them. And we are looking into really having a global menopausal study. So women coming together without, putting aside the global north, global south, but coming together as women and saying, we are one, and we there's more that unites us than that which divides us. And so I think the global menopausal study is one, but with Laura as well, we are also looking into solutions. What do women need if you are in menopause and you have vaginal dryness. So I'm really excited.
So if I may, Aura, what's your next stop on your destination or a next destination for your mission, Menopause?
Educate the GPs in this country to address the problem of menopause and talk to the women.
A worthy cause. Laura, your next destination on Menopause Mission?
Well, I am launching now my little company, which is creating these products for women. So that's really what I'm doing, thinking about the conversation and how to bring the conversation forward and how to educate women to talk about these things is really the next hurdle, I should say, hurdle that I have to jump over. So I think just thinking about that conversation is my next move.
And obviously, Nina?
I'm looking so much forward to our next meeting in the working group, which we have a physical meeting in the beginning of December in Vienna. And I'm going to take the conversation that we had today with all of you and bring that to the table in order to organize what are the next steps that we're going to do in the working group. And we might invite you to any sort of collaboration in the future. I'm really passionate about the education element in it, and I think that advocacy and education is something that goes hand in hand. So that's what I'm filled with right now, and then gratitude about having these conversations and then continuing to have these conversations is a good starting point, I think.
And I suppose gratitude is a wonderful word for me to also use in this context. I feel a lot of gratitude for you to allow me to be a participant in this menopause mission and in this conversation as well. So thank you so much for this wonderful webinar. And hereby we'll do our best to share it to the world and all of these wonderful words of wisdom.
Thank you so much, everybody.
Thank you, guys.
Mission Menopause is starting today, and we are not stopping.